time tracking as well? Okay, don't worry. Hello, I'm Dr. Susan Robbins. The class is Drugs and Society. Say hello to future viewing audiences, class. Wave. Say hello.
Hello.
Hi. Okay. Today we have with us Professor Mendy Snodgrass, who is a licensed clinical social worker. She's going to be talking about two different topics. Let me give you an introduction to her first. She's an assistant deputy at MHMRA. I had to ask her what that meant. It means she is an administrator, but she's an administrator who also does clinical work. She's also a graduate of this program many, many years ago, and a fully recovered attorney. When she first came into this program many, many years ago, she was a recovering attorney. Now she says she's fully recovered. So she works at MHMRA. She administers, she's responsible for several different programs, including one program on co-occurring disorders. In addition to that, in her past, she has been in private practice. She also works with the Montrose Counseling Center, so she's had a lot of experience in that area. And she's worked in the field of substance abuse and also with gay and lesbian clients. And the lecture today is a two-pronged lecture. Part of it is going to be on transmission of sexually transmitted infections, they are now called. They're no longer diseases, STIs, and how that relates to substance use and abuse, as well as how to work effectively with gay and lesbian population. So please, let's welcome Professor Snodgrass.
All right. Thank you, Dr. Robbins. This is sort of daunting, so I will try to be as relaxed as possible without falling out of the chair. And it's been my experience in doing a lot of lecturing and some teaching that what makes this more effective and more enjoyable for all of us is if we can have an interactive discussion instead of my sitting up here and lecturing. I'm not much of a talker anyway, despite the fact that I used to be a lawyer. Maybe that's why I'm a fully recovered lawyer now. And 3 hours of time in discussion where I'm the only discussing person is a little bit more than I can imagine. So I'm hoping that you all will be gracious enough to help me out a little bit. And I'm sorry?
You might have to call them by name to get them to interact.
Okay. Well, I am capable of doing that. I don't like to do that because it seems sort of punitive, but I will if I have to. So be forewarned. I'm going to talk first about substance-related issues in the gay, lesbian, bisexual, and transgender population. And then I'll spend a little bit of time talking about sexually transmitted infections, STIs, or what I've always called in my career STDs, sexually transmitted diseases, and the relationship between STDs or STIs and substance use issues. So first, there is a belief, and it's fairly widespread among professionals and lay people, that substance abuse is rampant in the gay, lesbian, bisexual, and transgender population. The truth is, that's not really accurate. There is a dearth of research to support that claim. The few meaningful studies that have been done regarding substance use in the gay, lesbian, bisexual, and transgender community have used such small sample sizes and compared such incomparable factors that they're not very useful. There's one study that's quoted widely that had only 10 subjects, and there's another that had only 30. So it's very hard to draw meaningful conclusions from the information that's available. It's surprising to me that there hasn't been more research in that area. But the reality is that there hasn't. Part of that is probably because it's difficult to quantify the gay, lesbian, bisexual, and transgender population. And you might be able to imagine some of the reasons why it's hard to quantify that population. Anybody have any ideas? Yes. Matt.
Well, I think that might be changing now, but certainly historically that was a population that had very good reason to not identify themselves.
Such as?
Gender phobia or homophobia. I don't know what all the terminology would be, but definitely like homophobia, just people, getting fired from their jobs.
Absolutely.
I mean, just very direct punitive action on the part of the state. I mean, sodomy was illegal in Texas up until recently,
yeah.
And had to go to the Supreme Court. So, I mean, there were good reasons to not self-identify. So it would be hard to gather that data.
Very good points. And the fact is that sodomy is still illegal in a number of jurisdictions. It's just sort of cloaked in a description of the act involving both homosexual and heterosexual contact. But it is still illegal in a number of jurisdictions. So yes, your points are very well taken. First, we don't know what the population is. The rule of thumb has always been that roughly 10% of the population is gay, lesbian, and if you add bisexuality in, it probably increases the numbers by about 7 to 10%. We don't know and have a great deal of difficulty quantifying who would fit in the category of transsexualism. And you'll discover as we discuss that why that may be true. There are some definitional difficulties in that area. And also there are a lot of people who don't self-disclose and won't self-disclose, especially when it comes to gender identity, because that is probably the riskiest area in terms of public reaction that we're dealing with now. You can see from this data that there's some disagreements about what percentage of the population might actually be gay, lesbian, bisexual, and transgendered. And part of that depends on how we define those groups of folks. Different definitions mean different outcomes. For example, if we say that people who have had same-sex experiences might fall into that category, then it vastly increases the number of folks who would be considered to be gay, lesbian, bisexual, or transgender. On the other hand, if we say that we only include people who self-identify as gay, lesbian, or bisexual, that reduces the numbers. So I wouldn't even begin to speculate about the numbers. The other, as I mentioned, confusing piece of all this is with respect to transsexualism or transgenderism, and we're going to talk about what might be the difference in those terms. But the SAMHSA, in all of its infinite wisdom, not too long ago said that 15% of the population may have had a transgender experience. I wish I could tell you what that means, but I honestly don't have a clue. If any of you all have an idea what that might mean, I would really appreciate your input on that. But it seems unusual to me that we would say that somebody has a transgender experience. That's just a difficult term for me to understand. I have had many years of experience in working with clients who are struggling with issues around their sexual orientation, their sexual or gender identity, and I have not encountered somebody who had what I would describe as a transgender experience. So I wish I could enlighten you, but I'm afraid enlightenment is not going to be forthcoming there. There have been a bunch of different surveys, again, to try to quantify who's gay, lesbian, and bisexual. The reality is that I would identify a client as being gay, lesbian, or bisexual if they told me they were, or if they described behavior that might support the conclusion that they were gay, lesbian, or bisexual. In all probability, I wouldn't express any opinion about that one way or the other. I wouldn't describe them as being gay, lesbian, bisexual, or anything in between. And I want to take just a moment to share an anecdotal experience about that. Many years ago, in my early days of practice, I had a client who was a priest. And that person came to me and described same-sex encounter. I proceeded to label that person as a gay person. And I never saw the person again. And there were some really serious problems that I might have been able to offer some help with. But I never saw that person again because I labeled them. And the label was not accurate because that wasn't how that person identified themselves. So it was a very painful lesson for me, but it's one that I think I've learned pretty well. I don't label people as anything unless they tell me that's what they are. If they have behaviors that they're struggling with, then we address those behaviors. If they themselves are struggling with how to identify themselves, then we might explore what possibilities there are for different labeling. But in any event, labeling is a complicated and not very accurate process when it's being done by some external investigator, like the Center for Disease Control or any number of other studies that are conducted. I want to talk a little bit about barriers that are associated with difficulties in collecting information, just general information about gay, lesbian, bisexual, and transgendered individuals. And if you can imagine that there are difficulties in collecting general information for folks who are gay, lesbian, bisexual, and transgender, you might imagine that there's even more difficulty collecting accurate information regarding their substance use habits. There is not a clear definitional model, first of all. So that creates a lot of difficulty in even trying to collect information. There are differences in culture, in the gay and lesbian culture versus the bisexual culture versus the transgender culture. Often for research purposes, all of these groups are lumped together. And that is probably not an accurate way to study this population. Although we talk about the population as if it was one cohesive population, and it simply isn't. Not all people within these cultures self-identify as any one of these labels. People may have sexual encounters with same-sex partners, and they don't in any way identify as gay, lesbian, or bisexual. They may have encounters with same-sex partners as a form of birth control. That's not a completely unheard of behavior in certain cultures. So there are a lot of factors that combine to make it very difficult to do research in this population. And as I mentioned previously, historically, the research sample sizes have been very small, and apples and oranges have been compared, and that method doesn't work very well, as I'm sure you all have learned in all of your research classes. Another factor that's really critical here is that assessment with respect to sexual behavior is woefully inadequate in almost every setting that I've ever worked in, particularly in the settings that are medical models or quasi-medical models, which many treatment centers are. Many chemical dependency treatment centers are. Issues regarding sexual activity or self-identification are not ever asked. Even in the setting that I work in, where we try to be especially sensitive to issues of gender identity and orientation, because some of these issues can be contributing factors in symptoms related to mental illness. It was 10 years ago when I first started working in the emergency services division of MHMRA that we first started asking any questions relating to sexual identity, orientation, partnership, sexual behaviors, at-risk conduct, any of that kind of thing. So if you can imagine that a fairly enlightened agency, I'd like to think, wasn't even asking those kinds of questions 10 years ago. You can visualize what it must be like in less enlightened settings. And a lot of settings that we're exposed to are sort of less enlightened. Sorry. Antihistamines have a tendency to dry out my mouth. Let me move on here. It's hard to reach any common understanding of the problems faced by the GLBT population if we don't have some sort of common language. So what I want to spend a minute trying to do is try to define some of the terms that you'll hear me use with some frequency today. Again, please, if you have any questions, don't hesitate to stop and ask me. There is nothing that you can say that would be nonsensical or useless in this discussion. Anything that you contribute is valuable. So I really do want to welcome you. And I know there may be some discomfort in talking for fear that you may not make as glamorous a statement as you'd like to. I certainly experienced a lot of that stage fright on my way here today, and then when I went to the wrong room, I experienced even more of that, and I'm just now beginning to kind of relax, and so I hope that you all will follow that lead and get a little more comfortable and be willing to share or ask questions. Orientation is affectional attachment. And a heterosexual orientation would be an affectional attachment to someone of the opposite gender. Homosexual orientation would be an affectional attachment to someone of the same gender. And bisexual orientation would be an affectional attraction to both people, both genders. So when we talk about orientation, we're not talking just about same-sex experiences. And I want to emphasize that because I think we have a tendency to think that if somebody has sex with somebody of the same gender, they're gay or lesbian. And that couldn't be further from the truth. That is really not an accurate statement. And as clinicians, if you all work in clinical services, if you make assumptions like that, it can be a very risky proposition, as the example that I gave you a little while ago might indicate. And so it's important to remember that sexual behavior in itself does not produce a particular orientation. It's also significant to note that, particularly with respect to males, lots of adolescent males have same-sex experiences that are completely unrelated to orientation and much more related to experimentation, much more related to feel good and figure things out. Biological sex refers to the anatomy with which we are usually born, the anatomical construction, if you will. Gender identity is not the same as biology or gender roles that are culturally assigned. For example, in Western European culture, we have typical roles that are usually assigned to males and females. Now, we could get into a very heated discussion, I'm quite sure, about whether those assignments are appropriate, but that's not what we're really here to discuss. The reality is that we do, in general terms, assign certain roles to males and certain roles to females, whether you like that or not. A transgendered individual, it's a little bit confusing because we have terms transgenderalism and transsexualism. Transgenderalism nowadays, and this was not true in the early days when I started working in this area, transgenderalism may be a term that's used to describe kind of a broad spectrum of what we would call gender nonconformists. So it could be drag queens. I'm assuming that you all know what that term means. Anybody who doesn't know what that is? Or drag kings, a less common term. Anybody not know what that term is? It's the same as a drag queen, only it's an activity engaged in by women who dress up as men and put on performances and that sort of thing. We have cross-dressers. Cross-dressers, interestingly enough, and this is just a little tidbit of information, are usually heterosexual men who like to dress up in women's clothing. Nothing aberrant about that. Transvestites. We have preoperative and postoperative folks who are, and this relates to specifically to transsexualism. And these involve people who identify with the opposite gender from their birth gender, who believe that they were born into the wrong anatomy, and who have chosen to live as the opposite gender. Yes, Ruth.
Is that transvestites, what you're saying, or transgenders?
No, transvestite is just cross-dressing. It's another term for cross-dressing. People who dress up in, and usually it's in women's clothing. I suppose it would be more difficult to be a female transvestite because we have relaxed the attire requirements for women so significantly that I am, dressed in what could be described as sort of male type attire. Back when I was young, it would certainly have been identified as male type attire, and it would have been unacceptable. But those standards or mores have relaxed a little bit. Preoperative transsexual folks are people who have not completed transsexual surgery. Most people, I think it's fair to say that the majority of transsexual individuals nowadays live in a preoperative state all of their lives. They do take hormone therapy, but the prospect of obtaining transsexual surgery is financially prohibitive for most individuals. Even if people elect to travel to another country, like Thailand, where transsexual surgery is more readily available, it's prohibitively expensive to make that travel and to engage in that kind of transsexual surgery. So many people live as preoperative transsexual folks all of their lives. There are also people who are postoperative, who have actually completed transsexual surgery so that their anatomy has been changed to conform to their gender identity. And it's important to remember, and there's probably more controversy, even in the mental health field, around transsexualism nowadays than there is regarding issues affecting gay, lesbian, and bisexual individuals. Many mental health professionals, even folks who work with gay, lesbian, and bisexual populations, have a lot of difficulty dealing with the concept of transsexualism or transsexuality, however you want to say it. And I'm not entirely certain what drives that reaction. I think that some people believe that transsexuals are just not willing to buck up and endure their gender and behave as they wish in the context of their own gender. I'm not entirely certain what causes that lack of understanding or empathy for people with transsexualism, who experience transsexualism, but it's there. I run a residential program for people with serious mental illness. Many of the folks in my program also have substance-related disorders. And over the years, we have acquired a reputation for serving transsexual clients. There are very, very few treatment facilities in the city that will serve transsexuals for some of the obvious reasons. There are struggles around what restroom is going to be used, shower facilities. If there's a question about sharing a room with a person whose gender is different from the birth assignment of the person in controversy, there are all kinds of issues that we struggle with, just practical issues, when you're dealing with folks who are transsexual, particularly when they're preoperative and therefore have not been anatomically changed. And there is a great deal of resistance that I've struggled with my own staff around being appropriate in the way that we deal with transsexual clients. I have an almost impossible task of getting a doctor who's even older than I am to use the appropriate gender identity for our transsexual clients. There's a persistence in calling the client, let's say it's Jane Doe, somebody who lives as a woman but was born anatomically as a male. I have a terrible struggle getting my doctor to call that person Jane Doe instead of John Doe, both to the client's face and in front of the staff and in any other setting. It's been a real struggle, and I think if you work with folks who are transsexuals, you will experience some of these difficulties. And I'm going to talk a little bit more in the chemical dependency treatment setting about the discriminatory practices, and I believe they are discriminatory practices that are engaged in this city in treatment programs. Yes, Ruth?
The clinic that I work for HACS. I don't know if you heard of HACS.
Yes.
I've been working with them for 10 years now. And when I started there, we had one person that came to work as a volunteer, was a transgender person. Mm-hmm. And it was hard for the staff to deal and how to talk to this person and everything. Years later, we had a transgender program, and we had staff, and actually they were the ones that educated the entire staff. And we started being a little bit more sensitive and careful the way how we talk. Now we do have a transgender program still. We do have a clinic, and I don't know if you heard Dr. Hamill.
I have.
He's our gynecologist that also does the hormone therapy for the patients. And we have a lot of transgender clients that started coming to the clinic this year. And it has been a change within the staff because everybody started, whenever you start first working there, it's kind of hard because if you haven't been around the population, you don't know how to refer, and it is really hard. Especially when you have somebody who's coming to do paperwork dressing as a woman and give you an ID with hair all over the place and a different name. And I mean, it is pretty hard. But we're learning. We're in the process of like, okay, well, we need to change our minds and, and it is not easy. It really isn't that easy. But, you're working and it's like, well, we're just people. So.
Well, and I think you make a really important point. When I think about an agency like HACS, that is one of the most progressive agencies in the state, struggling with how to deal with transsexual issues, it gives me a little bit better understanding of how enormous the difficulty must be for much less progressive organizations. And particularly when I know that the staff at HACS, there are lots of gay and lesbian folks who work there, but the level of sensitivity is a struggle. And I like the point that you make that part of what breaks down this struggle, and part of what helps people overcome these discomforts is education, is just meeting folks who are transsexual or meeting folks who are gay and lesbian. I've had clients who said to me, sort of foolishly, that they had never met a gay person. Now, how anyone could look at me and not know my orientation is beyond me, but I've had lots of clients who've made I guess maybe I look like a little old gray-haired lady sort of thing. But I've had clients who've said they've never known anyone who is gay. And, of course, I always struggle with, how do I respond to that? Usually I don't disclose because that's not appropriate in most instances. Every once in a while it is. Depends on what the person's issues are and what their struggles might be. But I really appreciate your input because I know HACS to be an extremely progressive organization. And the same sort of difficulties occurred at the Montrose Counseling Center back in the years ago when I first started working there. We struggled with issues of transsexualism and not being able to understand in the same way that I'm assuming heterosexual folks respond to gay and lesbian people sometimes, don't understand how it is that we are who we are and that we are drawn to the people that we're drawn to. What's a convoluting factor when we're studying the gay, lesbian, bisexual, and transgender population? And I'm going to kind of exclude transgender or transsexual folks in this discussion because I don't think that this model is really appropriate. But what makes research a little bit difficult is the notion that human sexuality exists in all probability along a continuum. At opposite ends of the pole, you have people who are, whoops, let's go back to that beautiful slide that my wonderful, fabulous administrative assistant created. I promised I'd give a plug on TV and everything for. But in any event, if you think of human sexuality as occurring along this spectrum, where at one end you've got people who are absolutely heterosexual, and at the other end you've got people who are absolutely homosexual, and in between you've got folks at all different gradations of orientation. And if you add to that the idea that this probably changes over time, it makes it a little bit clearer how difficult it may be to do research with this population of folks. And I just realized you're not seeing this picture, this beautiful picture. I'm not sure how to make it.
work.
Kinsey scale, we saw it.
You saw it?
Yes.
Ah, there it is. Okay, just one more time. No, my administrative, yes, did a lovely job on that. Yes.
Interesting phenomenon, a new term that is being used that I've heard, that I've not seen in any academic literature, but sure will make it into my next edition of my textbook, heteroflexible.
Sort of like metrosexual, is that?
Well, it's the notion that their main orientation is heterosexual, but in the right situation with the right person, they can be flexible and be bisexual.
Absolutely. And I have worked with clients who would fall into that category, absolutely. People who are primarily heterosexual or homosexual, who under the right circumstances might develop a romantic attachment to someone of the same or opposite gender. And once again, I'm losing my pictures here. John, could you add the slide? Whoops, now I don't have any slides either. There we go. There, you've got it. So we're going to talk a little bit about what we know about substance abuse and statistics in the gay, lesbian, and bisexual population. And it's not a lot, honestly. You can see from the data that's reflected on the screen that there's a huge publication that was put out by SAMHSA. And it's basically an introduction to working with gay, lesbian, bisexual, and transgender clients. They rely in that massive piece of work, it's about 500 pages, on 16 studies over the space of many, many years, starting in the 80s, that have looked at substance use in the gay, lesbian, and bisexual populations primarily. Some of the results are recited here. There is some reason to believe that lesbians, for example, abstain from alcohol less frequently than heterosexual women, and that they drink longer into their lifespan than heterosexual women do, at maybe a heavier level. I'm not entirely convinced that that data is accurate, because the study sample was so small that it really wasn't good research. But there is some contention that that might be true of lesbians. With respect to gay males, there is reason to believe, and there is some evidence to support the conclusion, that gay males have a tendency to use and maybe abuse on occasion party drugs of a variety of different kinds. Let's see. That's the lesbian issue. And party drugs would include things like methamphetamines, Tina. Any of you who watched Queer as Folk know that one of the big themes in that series, that wonderful, wonderful series on gay and lesbian life, involved methamphetamine abuse and the widespread problem associated with methamphetamine abuse. Don, could you load that? Thank you. MDA or MDMA, ecstasy, another very popular party drug. And it's important to understand that although the gay and lesbian population has gotten away from having bars as our social hub, as the center of our social world, it is still true that certain populations of folks, gays and lesbians, frequent bars and use bars as a source of meeting people, as a source of entertainment. It is in that context that we find a lot of substance use. I'm not prepared to say that it's necessarily the case that this involves substance abuse in any larger numbers than you would find in the general population, because I don't think the research supports that. There are people who claim that it does, but I don't think that the research is good enough to make a definitive statement. Ketamine, Special K is another big party drug. GHB, another very popular party drug. And there's a bunch of research here, again, not on great sample sizes, that will tell you that club and party drugs are used among gay and bisexual men in larger proportions than in the general population. I don't think there's been a lot of really good research on substances that are used at activities or events such as raves, which are predominantly heterosexual in their attendance. And I think if we had better numbers, what we might find is that the incidence of using party drugs are probably roughly the same in the gay, lesbian, and bisexual population and the heterosexual population. There are some factors that do impact gay, lesbian, and bisexual individuals and transsexuals that might contribute to abuse of substances. These are certainly issues that need to be considered in the context of doing clinical work with gay, lesbian, bisexual, and transgendered individuals. The first is the issue of heterosexism. Anybody know what that is? Without reading all this verbiage up here, anybody know what heterosexism is? It's a wonderful term. I'm really fond of it. All right, I'll tell you. Heterosexism is when we say that heterosexuality is normative. It's the standard. And anything that deviates from that is deviant, is abnormal, which probably in large part accounts for the fact that until 1973, homosexuality was considered to be a mental illness. Finally, in its infinite wisdom, the American Psychiatric Association changed the DSM so that gay, lesbian, and bisexualism is no longer, or bisexuality is no longer considered to be a mental illness. There are still vestiges of heterosexism in our society. Does anybody disagree with that? Because we could have a wonderful discussion around that issue.
It's
Dr.
more.
Robbins?
I think it's much more than vestiges. I think heterosexism is the dominant mindset of most people.
I think that's absolutely true. And it certainly has been my experience. As a very openly homosexual person throughout much of my lifetime, it has most assuredly been my experience. Although there's a great benefit in being disclosive, because I find that it's more difficult for people to discriminate against me when I'm straightforward about who I am. It's kind of an odd term, straightforward, but when I'm gaily forward about who I am. Homophobia. Now, anybody know what that is? Without looking at all this? Surely you know what that is. You're just afraid to chance a guess at the definition. Like any other phobia, homophobia is, well, and part of it, you don't have this up on the, Don, could you, whoops, okay, thank you. It's an irrational fear of homosexuals. And internalized homophobia, which I think many of us have to varying degrees, is a belief that there is something fundamentally defective in us, and that if we weren't so defective, we would be able to be heterosexual. I have worked with many, many clients over my years of practice who have serious internalized homophobia, to the point that one of the things that I encounter still in emergency services is suicidality among gay, lesbian, and bisexual individuals. Incidents of suicidality are 3 to 10 times higher among the gay and lesbian population, even now, than among the heterosexual population. And a lot of it involves self-loathing, self-hatred, and whenever people have the experience of self-loathing, there is a risk of substance abuse. Yes, Matt.
Yes, I was going to say that's one statistic that I would think would suggest that there probably is a higher incidence of substance abuse among gay, lesbian, and bisexuals, just because you look at suicidal completion rates, and it's like it is much higher, significantly higher, and substance abuse quite frequently is used as a maladaptive coping mechanism.
Absolutely. What you've said is extremely important. For people who lack good coping skills, and many gay, lesbian, and bisexual individuals are especially lacking in the development of these skills because they have not had the sort of familial relationships that have enabled people to learn good coping skills. No matter what, I know that I'm going to be okay. Whatever other people say about me, I still have the support of X, Y, and Z people. All that sort of self-talk that lots of people use as a way of anchoring themselves and as a way of coping. Yes, sir.
My work with the National Alliance on Mental Illness in the last 5 years, they've really scattered to, I guess, create more opportunities and equality within their consumer programming. And so, is there a correlation between the elements of mental illness tied in with the substance abuse? There's a lot of whys I have here, but I guess I'll let you take one chunk at a time.
Well, I would never say that there's a correlation between orientation and mental illness, because I don't believe that that's accurate. There is a correlation between people who are not comfortable in their orientation, not supported in their orientation, who experience internalized homophobia. And certainly between that and depressive disorders, anxiety-related disorders, and there is a relationship with substance abuse. Now, substance dependency is kind of a different issue, and I don't think there's any good research that supports substance dependency. But you're absolutely right when you talk about the increased risk of suicide and completion of suicide among people who are abusing substances, because we know that people who complete suicide are 50 times more likely to engage in that kind of self-destructive behavior if they're impaired. Whether it's an instance of single impairment or multiple situations where somebody has been abusing substances, I couldn't begin to say. But yes, it puts people at much higher risk. And I think it's fair to say that dysthymia or depressive disorders are associated with people who experience internalized homophobia. There is a connection there. Certainly, anecdotally, in my experience as a clinician, there is a connection. Don, could you load? Thank you. These are just some examples of how heterosexism and homophobia might contribute to an increased use of substances. And they're all the things that we've been talking about: shame, hopelessness, a belief that I'm never going to be able to break out of this cycle, I'm never going to be able to have the love and support that I need or want. And you factor that in with people who have not necessarily learned good coping skills from skills that are modeled by others, either family members or others in the community, then it does increase the likelihood, or at least it creates fertile ground for the use of substances as a maladaptive coping mechanism, just as you described. And for many individuals, if we layer on top of that the fact that they are rejected both at their familial level but also frequently at their cultural levels, because in a number of cultural or ethnic groups, homosexuality is not acceptable behavior. Bisexuality either. So folks experience kind of a double whammy that may contribute, if they lack good coping skills, to using substances as a way of coping. Yes, Matt.
I just wanted to share an example. It's kind of an extreme one, but to give people maybe a perception of how cultural rejection can affect someone. I worked with a young man at a wilderness program, and at some point in time, I think it was right before he graduated from the program, he shared with me that his mother, who was, I want to say, Nigerian, and she was an immigrant and had come over. He was born here, and I think he told me that he had maybe told her that he was bisexual. I don't think he said he was homosexual, although that's what he said was, I'm homosexual, but maybe I told my mom I was bisexual. And her comment to him was that that was bad and wrong, and that if they were still living in Nigeria, or she asked him, do you know what they would do to you if you lived in Nigeria? And he said, well, what? She was like, well, they would, throw you in a hut and bar the doors and burn, let it burn, and you'd be inside of it. And then she said, and I don't think that's wrong.
And sadly, the account that you've given is not inaccurate. I have had clients from different African cultures. Different cultures, yes. That's a brand new culture I've introduced you to today, and I'm happy to be the one to bring that to you. But I have had clients from various African cultures who have expressed similar sentiments, and who have also had acquaintances or friends who have experienced some terribly adverse consequences from their orientations. Yes, Ruth.
And there's within one of the indigenous groups in Mexico, I think it's in Oaxaca, that actually the mothers that have sons that are gay, they're blessed. That's what they tell everybody, that they are blessed because their son is the one who's going to be taking care of them. And you would have thought the rest of the country, there's so many machos out there, that the different cultures within the country, they don't consider that as a good thing. But this specific indigenous group, that's a blessing for them.
I'm so glad that you brought that up. I know a little bit about that group of that indigenous group, and that's a wonderful example of the absolute contrary developmental experience that some people have. And in certain indigenous populations elsewhere, bisexuality or homosexuality is embraced as a not only acceptable but desirable characteristic or way of being, or however we want to describe it. I don't want to belabor the point of religious oppression, but when we're talking about the gay, lesbian, and bisexual population at risk for substance abuse, it would be remiss of me not to discuss, at least briefly, the ways in which people are rejected by their religious cultures. And if they grow up in families that are devoutly religious, chances of being rejected both at the familial and at the social level in many respects are enormous. So I just don't want that to fall off of your radar screen as something significant when you're working with a client who may be gay, lesbian, or bisexual, and who might be struggling with those issues. Here we go. I want to talk just briefly about some of the assumptions that we make. And I think Dr. Robbins' comment is significant here, because it is true that heterosexism is the predominant view. And although we might not speak these in a public forum, many of us, I think, well, maybe us is not an appropriate term, but many people have these beliefs that all gay men are effeminate or Nelly, and that all lesbians are masculine or dykish or butch, and that all of us are pedophiles. Now, I hope that you know that the evidence is overwhelming, that pedophilia occurs 98% of the time among heterosexual males. Not to diss heterosexual males, but that is the population of folks who are predominantly engaged in pedophilia. That we are unstable and shouldn't be given high-level responsibilities. I have a client who is an extremely well-educated person who had a temporary position as a high-ranking executive in a lab, in a laboratory, a research lab. And when that person applied for the permanent position, was denied the position, and the evidence was pretty overwhelming that the reason for the denial was orientation, that the person was a lesbian, is a lesbian, and was not deemed able to fulfill the responsibilities of that job and to make an appropriate presentation in that high-level executive setting. That we cannot maintain meaningful long-term relationships, and I won't make some disparaging comment about how successful long-term heterosexual relationships might be, but you get the general idea, and that we are unstable or mentally ill. Did you have a comment, Doctor? I want to spend a moment talking about these pieces of evidence that demonstrate that heterosexism is alive and well in our culture. Again, if we're looking at risk factors that are associated with gay, lesbian, bisexual, and transgender status, these are some examples of why this population of folks are at risk and might use substances as a coping mechanism. We don't have legal protection. I could be fired from my job tonight or tomorrow morning when I arrive at work because I have disclosed to you my sexual orientation. And that is an absolute fact. The Employee Non-Discrimination Act has been promoted in the federal legislature and has not passed. It's now been kicked under the bus in the service of health reform, which I am 1,000% in favor of. I gladly would allow INDA to be kicked under the bus in the service of that need. However, the law or the act has been kicked under the bus for a million other reasons on previous occasions. Similarly, gay, lesbian, bisexual, and transgendered individuals can be discriminated against in housing. There is nothing that protects this population of people from housing discrimination. Don't ask, don't tell in our military is still alive and well, despite the hopeful comments that were made by President Obama when he was campaigning. And there are some very recent examples of how the don't ask, don't tell regulations in the military have been used to expel people from the military, people who have long, excellent service histories, who have been kicked out of the military because someone inadvertently discovered that they were homosexual. And there is no protection for people who have that experience. Continued enforcement of sodomy laws in a lot of different jurisdictions, and lack of support for gay relationships, particularly for gay marriage, or even legally sanctioned relationships in a variety of jurisdictions where that has been promoted and soundly defeated. The most shocking defeat, of course, was Proposition 8 in California, which produced some very negative backlash for folks who got married under the terms of Proposition 8 and later experienced negative fallout because of the act being overturned, of the proposition being overturned. So, if you could imagine for a moment what it might be like to live in a world where you're told that you can be fired because of who you are, or that you can't get married because of who you are, or that you can't serve your country because of who you are, might give you a little bit better understanding of how it is that gay, lesbian, and bisexual individuals might be at risk for using substances as a coping mechanism. Yes?
I think
Matt.
the Proposition 8 example is a really good one, but like also recently in Virginia, the new Republican governor and attorney general, they did away with civil unions. No, not civil unions, but I know that they're pressuring, I think, all the university systems to not have any sort of same-sex benefits. The laws have been on the books, and now they're basically they've rescinded a few of the statutes already. And so that right there makes it very precarious for the whole population, because that's pretty unique. You don't see that going on with most other places where rights are being taken away.
Well, but it's actually happened twice in my lifetime in Houston. I've lived here for 30 plus years, and on 2 occasions the city government placed propositions, or I'm not sure which, regulations, I guess, that extended equal benefits to partners of gay and lesbian employees. And those regulations have been overturned by popular vote, and they've been trounced. They've been beaten to a pulp. And it's an odd feeling to know that maybe your next door neighbor has been out campaigning to ensure that you might be deprived of benefits. It's an odd phenomenon. Not odd for people who belong to other disenfranchised groups, but it is a bit odd whenever you have that experience. And you know, one of the interesting things that a lot of gay and lesbian speakers talk about is that when they are the most threatening to others is when they are simply living a regular old life and introduce themselves to their next door neighbors, you know, 2 parents with 2.5 children and 2.5 dogs and 2.5 cats, and want to establish some sort of neighborhood friendship, that people react as if that's very threatening. And just something interesting to think about when you're working with these populations of folks, which, in fact, you will be. I want to spend a moment talking about special considerations that relate to transsexuals, because this has emerged as being the most difficult and dangerous issue. When I say dangerous, I mean danger to individuals who identify as transsexuals in our current social and political climate. This group of people are severely marginalized, and I think that that's even true in the gay, lesbian, and bisexual population, that transsexuals are marginalized, they're not understood, there's little empathy, there is often huge disenfranchisement from family, friends, relatives, church, work. And understand that for transsexuals, just getting a job is a much more overwhelming chore than it would be for me to just get a job. Finding a place to live, even a bigger challenge. Getting adequate health care, getting someone to prescribe appropriate hormone therapy, huge challenge, especially when I work primarily with people who lack resources. Well, I work exclusively with people who lack resources. And the absence of appropriate hormone therapy is one of the most serious problems that my transsexual clients encounter. And they are effectively reduced to one of two things. One is buying hormones on the streets of inferior quality and stepped on with things that we can't even imagine, with chemicals that are extremely dangerous. Or not having hormone therapies that enable them to live as they are, that enable them to live the gender that they are. I had a particularly painful client in the last year who was unable to obtain hormone therapy, and in the course of time that person was in my residential treatment program, not a chemical dependency treatment program, but a treatment for people with serious mental illness. The person really severely decompensated because of the inability to obtain hormone therapy and having to appear as somebody different from who they perceive themselves to be. That person struggled with a really severe addiction, and when I last saw the person, they were panhandling on the streets in downtown Houston. Not an unusual phenomenon at all. Homelessness is a huge, huge problem for transsexual individuals. Yes, Matt.
I interned with Healthcare for the Homeless Houston down at the Cathedral Clinic, and so
I thought I'd seen you before.
I think I've probably shot you emails as well, because it's always you're good people to know. But what I've noticed when we have clients in jail who are coming out who are transsexual, or sometimes when people come in off the street, what is very, very difficult as if it is housing. If somebody needs like an emergency shelter.
Absolutely.
I mean, there's I think one place that I can think of that will work with people that houses 8 people total.
Exactly.
So, and that's really a nightmarish scenario for individuals in that group.
Well, I actually, and I'm reluctant to tell this story because it's a painful story for me, but I had a client in the residential program who was ultimately discharged without a viable placement, longer-term placement. And this was early in the operation of this program, about 6 years ago. That person completed suicide. And after living in a tin storage building, and then eventually that was discovered and the person was required to leave that space, and the person completed suicide. And so I can't express enough the struggles that transsexual individuals encounter in just trying to carry out their day-to-day lives. So it's no surprise that substance use and abuse is very high in this population. I think it probably is fair to say, at least anecdotally, that I've seen more instances of substance abuse in this population in recent years, in the last 5 to 10 years, than I have in the gay, lesbian, and bisexual populations that I've worked with. We layer on top of that the fact that transsexuals are at risk of physical violence in ways that gays and lesbians were 10 or 15 years ago. Virtually every transsexual client I've worked with has experienced some level of physical assault. Some very, very serious. Others not quite so serious, but frightening and, leaving people without adequate coping skills nonetheless. Treatment issues with the gay, lesbian, bisexual, and transgender population, I think we've talked these issues to death. But I just want to mention, I want to reinforce a few issues. When you're working with individuals of any kind or character, it's important to do good assessments. I just can't emphasize enough that it's part of our responsibility as social workers to know what we're dealing with so that we can be of maximum service. If we don't ask questions, if we don't gather adequate information, we can't do our jobs effectively. If you have the privilege of working in a chemical dependency treatment program, it will be an enlightening experience for you, no doubt. The way that gay, lesbian, bisexual, and transgendered individuals are treated in the bulk of these programs, whether they're therapeutic communities or inpatient treatment programs or even outpatient treatment programs, is shocking. First, questions are not asked about that would allow people to gather any information about orientation. Secondly, there is no discussion in these treatment contexts about the issues that might be encountered by gay, lesbian, bisexual, and transsexual populations. Third, there is almost never any open visibility of gay and lesbian employees in these settings. Fourth, negative homophobic remarks are widespread. And I tell you this based on my experience of working in these settings and of running groups in these settings and of providing supervision for people in these settings. In my current program for co-occurring disorders, I contract with a large number of treatment providers out in the community. And because of my special sensitivity to some of these issues, I am fighting battles forever with treatment providers who don't believe that orientation is an important or meaningful issue. In these settings, there are also extremely awkward issues that arise around family therapy, family education, family sessions, and there is very little in the way of administrative intervention or policy intervention. It's rare that you will encounter a policy written by a treatment provider that says that heterosexism or homophobia or discrimination against transsexual individuals will not be tolerated. And here's the real bottom line. In the rank and file treatment programs in this county, transsexual individuals cannot be served. They are not served. They are refused service. It's hard enough to get an openly gay person into a treatment facility because there's, of course, always the danger that they might try to have a sexual liaison with one of the other residents, which I got to tell you, in all my years of work, just has not been an issue. But it's difficult enough to get a gay or lesbian or bisexual person into a treatment program. But it's virtually impossible to get a transsexual individual into a residential treatment program. I had one client who was sort of on an experimental basis admitted to a treatment program outside of Harris County, but one that I contract with. And although the treatment provider moaned and groaned and carried on in ways that I don't even want to bore you with, we did actually get that person through 90 days of treatment, an intensive residential and a supportive residential treatment program. After that, the provider told me that they would not do it again. So I was glad that it was an enlightening and positive experience for all concerned. But the bottom line is that services are not available in this county for indigent transsexual individuals in residential treatment, and difficult to obtain for gay and lesbian folks, if they are openly gay and lesbian. I have one provider now who simply refuses to treat openly lesbian clients because there are only a small number of providers that we can contract with. I haven't dropped that contractor yet, but it's a powerful temptation. Let's see, I think we've pretty much exhausted that topic. Just one, oh, time for break, sorry. Okay, we will continue with discharge planning after about a 20-minute break. Thank you, you're a wonderful audience. Never mind. I was praying for I thought that this would just make that automatically come up, but it doesn't. And we're back from break with just a few minutes of additional discussion on gay, lesbian, bisexual, and transgender issues in chemical dependency and substance abuse treatment and other similar issues. And I wanted to talk briefly about discharge planning in connection with treatment issues involving gay, lesbian, bisexual, and transgendered individuals. One of the things that is often not considered is the nature of the place to which somebody will be discharged, what kind of setting they'll be discharged to. And sometimes individuals in the gay, lesbian, bisexual, and transgender population will be discharged to settings where there's still a significant amount of use going on. They may be discharged to non-traditional relational settings. They may be discharged to the streets even. And all of those factors and the stressors that are associated with those kinds of discharges need to be taken into account when discharge planning is done. Gay, lesbian, bisexual, and transgendered folks also tend to have lots of health care issues that are not adequately addressed. And one of our responsibilities in doing discharge treatment is to consider what level of health care people have had. Particularly, transsexual individuals are less likely to access traditional health care than are most other folks. Lots of times because they've had really bad experiences in the past, as have gay, lesbian, and bisexual individuals at times in the healthcare system. We're going to talk a great deal about sexually transmitted diseases or infections in the last part of our discussion here, so I won't even include that as part of discharge planning, but just be aware that those are some issues that require attention in doing discharge planning. And we've mentioned before the whole issue of hormone therapy, but I just want to reiterate that in doing discharge planning, to the extent that we can be of some assistance to people in obtaining medically supervised hormone therapy for people who are being discharged from our care, that's a really good thing. One final thing to mention is that with respect to gay, lesbian, bisexual, and transgendered young people, there are not significantly great differences in their substance use than there are with heterosexual kids. Lots of times there are impulse control issues. Sometimes people make bad decisions. Lots of times young people experiment with substances. And that doesn't differ across the orientation span. So I really don't want to belabor that point or spend much time in discussing it. Sometimes gay, lesbian, bisexual, and transgendered young people have additional stressors in adjusting to or even beginning to explore their orientation issues. And those additional stressors may create coping-related problems, but nothing significantly different than you would encounter among heterosexual youth. I had to throw this in because it's really one of my favorite quotes in all the world by Lynn Lavner, and I won't go into any great detail about this, but you can read it for yourselves. Let's talk a little bit about STDs or STIs, sexually transmitted infections. There's still a lot of old people around like me who call them STDs, but they are STIs and substance abuse. And I want to spend some time talking about one of my favorite issues, which is the whole issue of harm reduction, which is probably not something that in this rather traditional, despite our recent mayoral election city, you won't find a lot of discussion, openly at least, about harm reduction models. But I do want to spend a little bit of time talking about that whole phenomenon because it is extremely relevant to the issue of sexually transmitted infections. What is important to know is that the incidence of HIV transmission, in other words, new cases of HIV, have increased significantly, especially in the population of people who are males who have sex with males, and particularly among people of color. African Americans are the largest population to be affected, but Latinos also are fairly widely affected. There is an increase in HIV among women who have worked as sex workers or prostitutes, whatever term you want to use, and usually that is connected to the use of crack cocaine and the fact that because of the whole nature of using crack, people have a tendency to go in rapid search of more and more and more of the substance because the initial high, and I'm sure this is information that you already have, it's about 17 seconds. It's a very profound and intense high, and people chase that high, high and low, if you will. And low is more like it. And there is an increased incidence among women who are crack users, cocaine users. And this is true both with respect to HIV and with respect to other sexually transmitted infections. So that's an important issue to consider. Texas has had an astonishingly large increase in newly diagnosed cases of HIV. And I have speculated about I've just mused about what might explain this dramatic increase. And I think part of it is associated with slacking off in the educational efforts that we in the grassroots gay and lesbian community in particular have made for many, many years, educating people about HIV and the risks associated with it and the need for safe sex and the methods for safe sex and on and on and on. And I think sustaining that level of awareness and education and safe sex practice is difficult over a prolonged period of time. And I think that the increase that we've seen in newly diagnosed cases of HIV, especially in male-to-male transmission, are a testament to the fact that we are not waging the educational war that we once were, or it's not having the desired effect. But I think it's really that we're not quite as vigilant as we once were. This is just more data about HIV and the populations affected by it and the increase in transmission. There are a disproportionately large number of people who are in lower income brackets who are newly diagnosed with HIV. They have limited access to health care, so they suffer more intensely. And this is just a graph that provides the same old information, demonstrates new HIV infections among males who have sex with males. Other STIs or STDs are on the increase. There are some theorists who believe that this is because of the maybe more widely spread use of substances by young people. I'm not sure that that's as true as it is that we are not engaging in safe sex practices and we are not promoting safe sex the way we once were, with the enthusiasm and widespread dissemination of information and outreach on the streets that we once used. Dr. Robbins.
It's also very difficult, I think, when you're working with a teenage population who believes that they're invulnerable, to get them to do things in their own best interest when it's something that they probably won't feel or see for several years down the road.
I think that's I think that's absolutely true. It's a safe sex and all that is attendant to it, including the risks of sexually transmitted infections, are not a real meaningful event for young people. With the same bravado that many of us once thought we were sort of invincible. I've begun to realize that that's not entirely true anymore, but I once believed that I was invincible, and with that kind of youthful enthusiasm for sexual experiments and using drugs experimentally and that sort of thing, I think it is hard to bring home the significance of unsafe and potentially self-destructive behaviors. And what the data that I have collected will show is that among young people in particular, rates of STI have increased. And they're pretty significant. And these increases are associated to some very large extent with substance use. Not necessarily abuse, but use. Now yes ma'am, Ruth.
One of my co-workers, he said that he was in a meeting from the Planning Council, the Brian White, and he said the city of Houston has done a like a concert, hip hop or something of that nature, and they have given 1,500 tickets to people to go to the concert. They tested the kids that went to this concert. He said that 10% of those kids came back positive for HIV. That's a large number.
It's a huge number. And I'm honestly not surprised, because the research that I've done, the exhaustive research that I've done in preparation for this class, really brought home to me those kinds of numbers. And they are huge, relatively speaking, a very large number. Dr. Robbins.
I think when we first learned about HIV many years ago, there was so much of a buzz about it, and it was being talked about all the time, because at that time it was a deadly disease. Very few people actually survived. Now that it is seen, and that's probably part of the reason why they changed it from disease to illness to infection, now that it is seen in many cases as a manageable infection, I think that there's not as much media about it, and therefore there's not as much public awareness about it. And people think, oh, it's them gay men. It's them gay men, and I'm not one of them. And people don't realize how at risk they are, because they don't know the person that they're sleeping with, how many other people they have slept with.
Absolutely.
And whether or not they have infections.
Well, and just anecdotally, I can share from my own experience in working with indigent, uninsured individuals, mostly homeless, and many with substance use issues. The incidence of HIV and other STIs that 10 years ago we probably wouldn't have even recognized. But the increase has been dramatic and really very noticeable. And I think explained in large part in the terms that Dr. Robbins used, which is that our level of awareness is diminished, and our view of HIV and other STDs as serious disorders or infections has also kind of diminished. We see them as manageable. Reality is that although they're manageable, HIV, for example, still is a very, very serious infection and potentially lethal, although not inevitably, certainly, anymore. And again, I think it's important to mention that the population of women who use crack, and the means by which folks obtain their substances, in particular crack, is by having sexual contact with others and without any knowledge of what their status is, what kinds of infections they may bring to bear to this situation, who they've slept with, what risks they've taken, or any of that kind of thing. And I can't begin to tell you the number of clients I've worked with who have acquired an STI of some sort, whether it's HIV or another, like syphilis or gonorrhea, who have said, you know, it was my drug-seeking behavior that brought me to this place. Sadly, I think the people who are most strongly impacted are people in lower socioeconomic groups, and often people who are otherwise disenfranchised, people of color, for example. At least that's been my experience. There's also been a rather alarming increase in the population of folks that I serve of tuberculosis. And again, probably in large part a product of unsafe practices and inadequate education. Here is another, just another visual of sexually transmitted infections among young substance abusers. And there is a lot of emphasis in the research that I did on young people abusing alcohol in particular, because that's kind of a given activity. Not many parents are violently opposed to the use of alcohol, and it's certainly widespread among young people, but the way that we treat it is without adequate education, I think. There's very little information disseminated. And one of the things that I'm going to talk about in the context of harm reduction is the importance of giving information and then allowing people to make their own decisions about how to use the information that they're given, but the importance of giving that information in the first place. Again, more information about the impact of STIs on young people. Young women are the most dramatically impacted by recently diagnosed STIs as a result of making bad judgments when they are impaired, either through alcohol or other substances. And the reality is that we all know this, we make bad judgments when we're loaded. That's just the reality. We do stuff that we probably wouldn't do if we weren't otherwise impaired. That's why it's called impairment. And there are some special considerations among methamphetamine users. One of the very interesting things that I learned in connection with this research is the increase in STIs among people who live in rural areas because of the widespread dissemination of methamphetamines and the fact that it decreases inhibition and increases libido. And so there's a lot more sexual activity around methamphetamine in certain groups of people. And we see this a lot with respect to males who have sex with males. There are certain populations of folks who use substances, methamphetamines, and other kind of party substances as part of their social ritual. And unfortunately, in doing that, folks, again, make some bad decisions and take some risks that they might not otherwise take. So what do we do? How do we solve these problems? Now, there are many things that can be done to deal with substance-related infections, illnesses, and other kinds of problems. And I'm not going to try to cover all of those bases. And I know that you've probably talked ad nauseum about these subjects in other classes. But what I want to talk about is about the concept of harm reduction. It's important for all of us to remember, I think, and especially those of us who get in the groove of doing work with folks who are substance abusers or substance dependent. This is not a one-size-fits-all science. And when we are bound by that view, I think that we alienate a lot of folks that we would really much rather serve. And for example, among the population of people that I work with, many of whom have a wide variety of sexually transmitted infections. Probably 80% of the people I work with have hepatitis C, sexually transmitted or transmitted through the use of needles, of infected needles. And many of those folks have hepatitis B as well. Very, very serious sexually transmitted infections. When I talk to those clients about going to treatment, and I think that I'm offering them this wonderful gift, they look at me like I've just sprouted another head. And they say, not on your life. I've been to treatment 23 times, didn't do anything for me the previous 23 times. Why would I spend 90 days in treatment now? And besides, I've already been to that place and that place and that place and that place. And so what I'm not allowed to do, although I do it anyway, is I'm not allowed to say, well, then let's look at how we could create a situation where you might be less at risk in the use that you engage in. You know, you're not going to quit, you're not going to abstain. I'm fine with that. It's not my place to make that decision for anybody. It's certainly not my place as a social worker and a mental health professional, but particularly as a social worker, to try to tell someone else that they are obligated to abstain. That's not my job, not my role in somebody else's life. So we try to problem solve. The difficulty is that we have to do it kind of on the down low, because in the traditional treatment model, which involves the therapeutic community, abstinence is the only acceptable method of treatment. So when somebody comes to me and they say, I have been engaging in unprotected sex because that's the only way I can get crack, I'm supposed to say, well, we need to set you up to go to treatment. And of course I do say that. I offer that as the first line of defense. In more times than not, my clients are simply not interested in that option. Even though I've worked for many years to establish a free 90-day treatment program for people who are indigent and uninsured who have co-occurring disorders. Even with all of this hard work that I've done, people are so ungrateful that they refuse to go to treatment. And so, if I'm really going to do my job, I have to help people problem solve, develop their own problem solving skills to identify ways in which their risks can be reduced without requiring them to abstain from the use of substances or other practices that are risky, like having sex with multiple partners, which many of my clients do because they want to. And who am I to say they can't or shouldn't or make any of those kinds of judgments? That's not an appropriate, in my opinion, and this is only my opinion, that's not my role as a clinician. Dr. Robbins.
And Mindy, even if you did tell them you shouldn't do that, they'd still do it.
And you're absolutely right. And perhaps my strong opinion is born of experience, which is that in the early days of my work, when I told people, you must do this and you must do that, they looked at me and said, uh-huh, and that was the last I ever saw of them. Yes, sir.
I was just wondering, does there ever come a point within this clientele that their behaviors catch up with them and they start slowing, like I've heard from a lot of friends who are recovering addicts. Eventually that behavior, it catches up and then they slow down and they find meaningful recovery in their lives. Does that translate over to the GLBT community as well?
Absolutely. There is a huge percentage of the gay and lesbian population, GLBT population, in recovery. There are gay, lesbian, bisexual, and transgender groups of Alcoholics Anonymous all over the country. There's a huge club, a Lambda club in Houston. There is a Lambda group in Clear Lake, and in other cities and states. There are huge populations of gay and lesbian, bisexual, and transgendered folks who are abstinent and in recovery models that are built on the notion of abstinence. 12-step programs are the programs that I'm traditionally or typically referring to. So yes, there are large numbers of people in the GLBT population who are abstinent and for whom that is the goal. For many of my other clients, ultimate abstinence is some sort of desirable value. I mean, it's something out there as a desired goal, but they're just not anywhere near reaching that goal. And one of the neatest new developments in substance use theory is the whole concept of readiness to change and motivational interviewing associated with readiness to change that has been brought to the fore among substance use workers. And readiness to change is really another statement of a harm reduction model. And all it says is that we meet our clients where we find them. So if we have clients who are engaging in risky behavior because they have impaired judgment due to their substance use, and they're not ready to abstain, they're not at a change level that would support abstinence. They're not there. And it doesn't make sense for us to exhaust our efforts on that model when we might be able to help them with another approach. And that's what harm reduction is. It's simply helping people find a way of continuing to use that is not going to create the difficulties for them that their previous use has created. There are a couple of things that are inherent, a couple of assumptions that are inherent in a harm reduction model. And please stop me at any time and in particular, I'm interested in hearing from people who disagree with this model, because it's a very, very controversial model among substance abuse professionals. It's a hugely controversial issue. So if any of you have any of those kinds of issues and concerns, I really welcome your intervention. Yes, Matt.
I have a question. I actually just watched a video on harm reduction, and conceptually, I can definitely wrap my head around it, and I think it makes sense for perhaps a large number of people. But I'm also thinking about some individuals that I know, people that I've encountered who their substance use is compulsive, and such that, you know, if they have one drink, you know, they'll be drinking rubbing alcohol before the night is out. And I wonder, with the harm reduction strategy, are there certain individuals that it's that it just doesn't work with at all? I'm assuming there probably is, just like anything else, but
I'm not sure that I would say that there is anyone who wouldn't benefit or couldn't benefit from harm reduction. Now, admittedly, there are some people who are so physically dependent on substances like alcohol that it would be a huge challenge to use a harm reduction model. But there actually have been some harm reduction programs with alcoholics that have been wildly successful. Now, keep in mind, these are people who are not seeking abstinence. These are people who will say to you, and they'll look at you and say, I'm a drunk, that's who I am, I have no intention of stopping. If you have some better suggestion, bring it on. Dr. Robbins.
Yeah, let me address your question, Matt. What you're talking, let's not confuse harm reduction with moderated management of drugs. Harm reduction is a much broader policy that refers to many things, and we're going to be talking more about this. When people tell me that they're not ready to quit, that they want to try using less or using more wisely, who am I to say no? Let's start with that. I can point out to them that that hasn't been their pattern in the past. When they've tried to do that, they failed. But if you say, no, you can't do that, what's going to happen? They're going to get sober, and then they're going to go back to drinking again. As you said, the first time they take a drink, they're going to be back drinking heavily. I think if you're working with clients, it makes more sense to let them try and fail, to let them see that they can't do it. Because if you say, no, that's not going to work for you, you're already engaging in a power struggle with them that you're on the losing end of. Does that make sense? So, yes, let them try it if they want to try not abstaining totally, and then see where it gets them. And then you can go over the consequences of that with them until at some point, if they are not a good candidate for cutting down as opposed to stopping entirely, at some point they're going to eventually see that.
And that's actually where this wonderful technique of motivational interviewing comes into play, helping people come to the conclusion on their own that they need to make some significant, meaningful changes in their behavior. I have worked in this field for many, many years, and I can tell you with absolute certainty that I have never been able to make a client do what I told them to do or wanted them to do. Not ever, not with respect to any single issue. The thing that I have succeeded in doing is alienating clients and making them really mad and running them off. When I tried to impose my values, my views, my beliefs, and my assessments of them on them at a point in time when they're not ready to make the kinds of changes that I'm demanding. And so I am with you 100% in recognizing that there are people who are so debilitated that moderating their use is just not going to work. But for me to tell them that is also not going to work. What may work is for them to learn that on their own with a supportive worker who says, I'm with you. I'm going to be right here. You go out, you try this, and come back next week and tell me about it. And let's see how it worked out, how that worked for you. Drinking only beer. Yes? Ruth.
A few years ago, with this agency, I had the chance to work with an evidence-based program, and it was a risk reduction or harm reduction program. And one of the things that we talked to the clients was, I want you to tell me what is your goal. You want to tell me that you want to completely quit? Let's see if you're ready for that. If you're telling me that you want, instead of drinking every day of the week, you want to drink 6 days of the week, then we work with that. So we actually were going with what they were saying. So at this point, a lot of us were so tempted to tell them, well, you need to stop. But it's not our goal, it's their goal.
Absolutely. And that's really what harm reduction is about. It's about recognizing the rights of our clients to make their own decisions about their lives. Yes, sir.
I appreciated the way you segued from harm reduction to motivational interviewing. It's just, I think for a lot of people, a lot of the times, harm reduction topic can sound like, oh, well, if they don't want to do it, then let's just make it the least painful or the least harmful, or let's just, let's give them an excuse. But I like the way you tie the two together and throwing in that therapeutic side of that interviewing, like Ruth was talking about, to where they're at and helping them understand more about their own goals and such.
Well, and it really is what social workers do. I mean, person in the environment,
theory,
and
yes.
self-determination, and meeting our clients where we find them in ways more profound than in other disciplines. That is what we are expected to do. That's what our profession is about. That's what we do. We meet people as we find them, wherever we find them. And then we have the privilege of walking along the path with them in the realization of their goals, not ours. And that's a hard thing when you see someone destroying themselves, or what we perceive to be self-destruction. It's hard to watch. It's painful. I don't like it. But I like it a heck of a lot better than I like losing a client, because I tried to force them into a square peg when they were still round. What a brilliant analogy. Let's talk a little bit about the necessary elements of harm reduction. Next slide. Harm reduction assumes a couple of things. One, it assumes that some amount of substance use is always going to take place. It's just a part of reality. And this is any program or policy that's designed to reduce the harmful fallout from substance use, but without requiring necessarily the abstinence from substance use entirely. And it really does focus on personal responsibility and personal accountability. And one of the neat things about harm reduction is that it embraces people instead of shunning them. Instead of beating people up because they have not been able to maintain sobriety, the worthless piece of poops that they are, harm reduction says, well, you made a good plan, you've given it a good shot, you've been able to reduce the adverse effects of your use in some areas, maybe not so great in others. Let's tackle these other areas now, and so on and so forth. There are some really neat examples of harm reduction that are currently alive and well in Vancouver. There are a few even in Seattle, not many. Very few, actually, in the States, with the exception of some very progressive treatment locations like New York City, with the Housing First models that have been adopted there, phenomenally successful programs where homeless folks, the need for housing has been recognized as the preeminent need, from which other benefits, enormous benefits, flow. There's lots and lots of research that demonstrates that in Housing First settings, people get better at a whole bunch of different levels. They start taking their meds if they have to take meds. They stop drinking or drugging as much. They stop engaging in as many irresponsible kinds of risky behaviors. Just an amazing array of benefits just stemming from the Housing First model. Yes, Matt.
Just thinking about the theory in general, I mean, it obviously flies in the face of like the drug war, which is one problem, the criminal model, but also just the absolutist thinking that we seem to have in our country. You know, it's either good or bad. It's yes or no. It's ones and zeros, and not things don't work on a continuum. It's either this or it's that.
Well, and I think that it illustrates the sort of infectious, illogical thinking that we engage in this country, where we try to make things be black and white, when the reality is that almost nothing is black and white. Almost everything is gray. And to say otherwise is really irrational. But that's an irrationality that is very widespread in this country. And we're not alone in having those absolutistic, perfectionistic views. Not at all. The simple concept of having designated drivers and free cab rides and low-cost motel rooms for people who've been out partying at big events or whatever is an example of harm reduction. And do you know what's happened? We've had a dramatic decrease in drunk driving accidents just because of this little harm reduction tool. And the numbers, if you look at the data, it's really astonishing. Over a span of about 10 years, the number of drunken driving accidents has reduced incrementally. It's really been pretty amazing. The use of methadone, and more than the use of methadone, the regulated use of heroin as a maintenance drug for opiate addicts. Very successful, very expensive, but very successful. Methadone, not so successful. But using heroin as a maintenance drug, a maintenance medication, has really produced very good outcomes in other countries, in Europe and primarily in Europe. Needle exchanges, another example of something that, you know, in all the research that I did, and this really astonished me, I discovered that the number of new incidents of HIV among injection drug users has decreased 40%. Why do you think that is? Is it because the number of injection drug users has dramatically decreased, do you think? I don't think so. Not according to my clients, many of whom are injection drug users. It's because needles are more readily available. It's possible, and the very simple notion of not using infected needles can dramatically reduce the number of sexually transmitted infections in this country. And you know, this sounds like such a simple, mindless thing, but the realities are very profound. Yeah.
I was reading a book that Professor Robbins had shared with me, and it's called Smoke and Mirrors. It was written by a journalist, but he's talking about heroin use during the Vietnam era and how initially the heroin was almost absolutely pure, such that like GIs were drinking it. Yeah, I mean, you could and getting extremely high and feeling quite good. And then after the government started to crack down, like really tried to keep the GIs from using this, that's when all of them started to shoot up. But it wasn't until they started to basically interdict the drugs that led to this much more dangerous behavior. Absolutely. Because the purity went down and they started to shoot up. And so it's like, because you just mentioned that, but this data, it's around and people are aware of it, that it's leading to much riskier behaviors, but it happens anyways.
Well, and in almost every instance where we criminalize behavior and where we dramatically restrict access to regulated substances, you're going to see those same results. The level of harm dramatically increases. And we've seen that across drug use history for all the years that I've been alive, all the many, many years that I've been alive. But bottom line is this simple needle exchange thing, ready access to needles, has made a huge impact, and it's a simple harm reduction technique. I am a huge advocate of decriminalization of drugs. And it's not because I want license to go out and use every substance to my heart's desire, or that I want that benefit for anybody else, but it's because I work in the trenches, in the ravages, among the ravages of people whose lives have been destroyed because their substance use has been criminalized. I have a colleague who was sentenced to 15 years in prison for having less than an ounce of cocaine. First offense. Deprived of the opportunity to get a PhD or a license, at least thus far. That does not make any sense. It just doesn't make any sense. If you know anything about the prison system in Texas, you know that that there are people hanging from the rafters who have never had an offense other than a substance-related one. And we do some really brilliant things, too. My all-time favorite law is that we say that people who have substance-related offenses can't get food stamps. Do you see the brilliant logic of that? We're going to starve people who use substances to death, and maybe that thereby reduce their numbers, and in turn reduce the number of people who abuse substances. Right? Brilliant. I just don't get it. It doesn't make any sense. People who have gone to prison for substance use can't get work. They can't get jobs. I'm sorry, but it does not make sense to me. And I really try to be reasonable and mature about it, but I just can't get it. Yes?
Well, it definitely seems to be like a self-reinforcing cycle. So you criminalize someone, put them in jail, they get out, they can't find legal work, which is probably depressing and sad anyways, and so you're going to probably go to a bad coping mechanism, and it's like you can't find legal work anyway, so why not deal drugs?
That's exactly right.
But it doesn't seem like, and I don't know how many people would even say this anymore, but it doesn't seem like our prison system is about rehabilitation. I don't know if anybody would actually make that argument these days or not. Like, even the people who support building more prisons, I don't think they're like, well, we need more prisons so we can rehab people. I think it's more about just punishment.
Punishing, yeah. And it's worked so effectively, really. It's just, the results are just astonishing. It's really been a useful tactic. Decriminalization in other countries has worked very effectively. It does all sorts of positive things, including providing penal systems for people who actually probably do need to be segregated from other folks in the world for some prolonged period of time. Look at that. That's cool. She's amazing, isn't she? And this is a really hot topic right now. In several places, mostly in Australia, Canada, they've set up safe injection rooms where people can go and use injection drugs in a setting where there are 24/7, there are staff members present who can do CPR and other routine health care kinds of interventions. And they provide clean, safe needles and clean, safe space. And in the main, they have been effective in reducing the number of sexually transmitted infections, because people also get information and condoms and other stuff that's useful at the same sites where they have this nice, safe place to go. The only negative effect that I've seen in the research is that some places people overuse because they know there's going to be somebody there to resuscitate them. So they take risks that they probably wouldn't take out on the streets. So that's kind of an unintended consequence of what was otherwise a pretty good idea, probably. You know, I don't even want to go into my song and dance about legalization and decriminalization of pot and other stuff. Please understand, by the way, I am a recovering person. I am an abstinent person. But that doesn't mean that I would impose that practice on anybody else. That's my choice based on some painful, difficult learning experiences that I had. But I don't want you to think mistakenly that I'm coming here as somebody who is going to leave here and go out and get loaded and smoke all sorts of pot and snort some cocaine and inject some drugs and have a really fine time, because although I've done that, I'm not going to do it again, I hope. But it doesn't mean that I don't have very strong views about the benefits of a harm reduction model in a variety of different settings. One of the most interesting undertakings, and the most successful program that I'm aware of has been undertaken in Toronto. This is my dream, working with the homeless population, is to be able to provide a wet shelter for my many, many hundreds of clients who are drunks and who can't or won't ever take the benefit of shelter because it means they can't use. And it means I can't drink. And these wet shelters regulate the consumption of alcohol. Most of them have the model of receiving a glass of wine per hour until somebody becomes so inebriated that they're not able to function at all, and then, you know, they'll be stopped for a little while. But these have been wildly successful in terms of the outcomes that really matter to an economy that is suffering, like decreased visits to emergency rooms, decreased calls to emergency service providers, decreased fights out on the streets and knifings and all that kind of stuff. And amazingly enough, decreased consumption of alcohol.
Is that a correct number? 46 per day?
Yes. Yes. That is an accurate number.
Is that based on an individual, or
it's
based on an individual or like a group? Or?
It's based on a study that was done, and I can't remember now the number, but there was a significant number in the study, and I wish it may have been 200 or something in that neighborhood. Dr. Robbins.
There's always a problem with self-report on how much alcohol people drink. So when you ask, well, first of all, what does alcohol do? It impairs your memory.
Good point.
Okay, and heavy drinkers, they're just taking guesstimates. But there's a big difference between somebody who is drinking from the moment they get up and continue to drink after drink after drink without waiting an hour for the next drink, as opposed to somebody, and I'm sure that measure of 8 drinks a day is very accurate because there are staff administering them.
Exactly.
So it's very hard to get a really good count on how much people actually drink if you're going only on self-report, because alcohol does impair memory.
Very significant point. I can tell you with absolute certainty that of the alcoholics I've worked with, I'm very certain that none of them limit their intake to 8 per day. I can just promise you that. Now, I couldn't tell you what the exact numbers are, but I can tell you that I don't think these numbers are really far off, given the amount of work that I've done with folks who are seriously impaired alcoholics, seriously physically dependent. And like Dr. Robbins says, these are people who, from the moment they wake up in the morning until the moment they pass out and are revived again, are ingesting alcohol because that's what they have to do to function. Let's see if there's anything else you may be able to escape just a little bit early. Oh, there are some neat things that are being done in harm reduction associated with raves and other sort of party activities of that nature. One of those is the program called Dance Safe, and they actually test the quality of pills that people purchase at these events, not making any judgments about whether people should use them or not, but reporting to people if they've gotten harmful substances. Because as you probably know, raves are notorious for people getting really, really sick and sometimes dying from the impure substances that they ingest. There's another program called TRIP, and they set up at raves and just give people information about safe sex practices and provide them with kind of a safe space to rest and relax and get some water and just kind of chit-chat without, again, making any kinds of judgments about what people should or should not do, but making educational information available. And we all know, all of you who are in this graduate program, know how very incredibly valuable education can be. Dr. Robbins, did you? Okay. And I really think we are nearing the end. You know, there are a number of tobacco reduction initiatives. There's a huge ongoing controversy about smokeless cigarettes, e-cigarettes that are well, they're smokeless. I'm not sure what their content is, and there's a lot of controversy because they haven't been tested over a prolonged period of usage, so nobody really knows what the ultimate potentially harmful effects of these things may be. Certainly we know something about smokeless products like chewing tobacco and snuff and all that sort of stuff, which is carcinogenic, but certainly not to the degree of inhaling cigarette smoke. And certainly the dangers of secondary smoke are eliminated by smokeless products. An initiative that I'm very interested in and trying to, in very covert ways, promote are safer practices for people who smoke crack and who are going to keep on smoking crack. Using safer pipes that are not handed around among 100 different people, putting 100 different people at risk. And another really huge issue is not using Brillo as a filtering system. People actually inhale little pieces of metal when they use Brillo, and eventually this can be damaging, seriously damaging to the lungs. And so using some other kind of a screen, some safer product is part of the harm reduction effort that's being made with respect to crack use. And does anyone have any questions, comments, insight? Dr. Robbins.
Another example of harm reduction that is used in the Netherlands, or was used, was for kids who huff gasoline, paint, and other kinds of fumes, is teaching them not to huff until the point that they pass out.
Absolutely.
Because that makes a very big difference in the amount of brain damage that could potentially occur.
And there are some other pieces around huffing. Kids who insist on continuing that behavior are taught safer practices like using paper bags instead of plastic bags, and avoiding flammable substances, or at least areas where they might be at risk of coming in contact with an open flame. Lots of different safer practices for kids who are going to continue to huff. And anybody who doubts that kids huff, I'll be happy to share with you some of the gruesome anecdotal stories that I have acquired about kids who huff and have huffed. And Don, the last slide, please. One of my colleagues absolutely promised me that this was a totally breathtakingly brilliant statement that I came up with, so I really hope that you will appreciate it. You know, we have a tendency to reject the notion of harm reduction because it really does deviate from the training that most of us have received, and to some extent from the value that we have embraced, the notion that abstinence is essential, but it's kind of like the old notion of throwing the baby out with the bathwater. If there are ways that we can work with our clients to help minimize the harm to them, given that you will encounter many clients who will outright refuse to abstain. If we can work with them to find more reasonable ways of doing what they do, then we will have served them well. And I just want to encourage you to be open-minded enough in your work to maybe color outside the lines. And I think that's it. Dr. Robbins.
Not so much how do you, because I know you've been in the field for a long time, what would you advise to people who work in agencies that say, this is our policy, you must follow our policy does not include harm reduction? I got to give you the hard question.
Well, I can only share my own experience, strength, and hope, which is that I'm aware of those policies, and my agency has those policies. But what I say to a client in the sanctity of my office in a clinical session is that it's sacred, and nobody can invade that space unless my client chooses to disclose. And what we work with and the recommendations and suggestions and issues that are explored in my office or my groups are therapeutic and confidential. So my agency doesn't necessarily have to know about any of those things. The other thing, and Matt, just 1 second. The other thing, honestly, is that if I can assist my client in making decisions that are helpful to them, that improve their overall quality of life and their well-being, then honestly, I am willing to take the risk of erring on the side of suggesting harm reduction when there is no other viable alternative. Now, I'm also a lot older than you all are, and so I can more easily afford that risk than you can. Matt.
I was just kind of following up on that question. When you're working with a client, is that something then that you would put in your notes? And I don't know how.
I would put some general reference to exploring options, looking at various possibilities for managing use. Client stated goal. I can always say they stated their goal is this or that or the other. Explored ways of achieving the goal. Recommended this. Client said no. There are ways to document. There's always a way to document. Dr. Robbins.
I'm going to take this to a broader perspective. I think it's important to recognize that many of the agencies that are funded for substance abuse treatments have funding based on the fact of zero tolerance and abstinence only, and we have to recognize that. But I think we also have to recognize that we are agents of change. In addition to possibly working in harm reduction ways with clients, if that's what clients desire, I think it's really imperative for us to also be agents of change and try to see how we can get policies to change, not only at the agency level, but also at the state level. And I realize that that's a bigger and more long, what's the word I'm looking for? More protracted battle, let me put it that way. But I don't think we should give up on policies that we see are viable policies, all because our state doesn't embrace them at the moment, because we have to believe that change is possible and that we are agents of change.
Absolutely.
So I'm going to leave it on that up note.
And to that end, I have at long last, after so many years in this profession, been appointed to a state work group where I may have the opportunity to do some little something. Yes, sir.
What kind of abilities with research?
I'm curious about your abilities and what kind of opportunities you see as far as gathering more data and information to use for good, for papers, or what other opportunity do you see for yourself?
Unfortunately, in my agency and in my work, we're really not a research facility, and the hoops that I would have to jump through to actually put a research project into place are virtually untenable. But I'm certainly willing to undertake any sort of research or data gathering on an anecdotal level. I can certainly do that and try to do that. And I certainly have made some plans to work with a colleague to set up a program in our retirement days where, and it's a model, it's called the Delancey Street model. It's a model where folks actually manage their own environment, they do their own work, they manage their own property, they have a place to live. Using is, well, abstinence is the ultimate goal of this program, but people are not penalized for using as long as they make some effort toward the goal of ultimate abstinence. And it's a self-actualizing model. It's really a phenomenal model. And we have some property, and we're going to put this program into place. And so that's, I'm not sure that's responsive to your question.
Oh, yeah. I was just interested in the other ways we get to learn from all the knowledge that you've gathered over the years.
You know, the wealth of knowledge I have is all because of the privilege of being able to work with people individually and in groups. And I'm not, I don't have the benefit of doing much formal research, but there's a lot of research that can be done in a community setting. And mine is very ripe for that kind of work. Very, very ripe in other ways as well. Any other questions, comments? You've been phenomenal. Thank you.